Well, let's discuss this adjuvants, what we use, because Goody just thought I purposefully asked on testosterone to him, but then we will understand this testosterone supplement a little better when we look into this. I'll forward all of you this article. There was a bunch of articles published in views and reviews by Fertility Sterility 2 years back, and it was all on adjuvants only. And just after that publication, in 2 months' time, I had got an invitation from IFS Bangalore for this lecture. So let's make an academic point first. So IVF, let's say we have 30% success. Not for Mumbai, they all have 70%. But not for Nova and the big people. So he kadaisa, mallar he edit karaisa. So I mentioned, so he records them that this has to be edited. Because all those big people have big success rates. So we all have simple success rates, 30%. Adjuvant will increase the success by 20%. Let's assume that adjuvants increase the success by 20%. It's just a theoretical point. So you will have 30 patients in control group and 36% in the intervention group will get pregnant. Am I right? If you assume that. So you will need your 2,000 patients need to be randomized. And at this juncture, you don't have a single adjuvant trial where 2,000 patients are randomized. You got it? So the truth evidence does not exist. So let's say anticipated incidence is 10%, group 2 is your treatment incidence 12%, and you put it and type 2 error rate, everything's 80% power, everything, and just put calculate. Look at the sample size, 7,682. Where is a trial? There is no trial. Such big trials in obstetrics and gynecology only exist in fetal medicine. The huge trials published because so many women get pregnant. Okay, huge trials in fetal. You go to a fetal medicine conference, you are aghast, oh, 12,000 patient, 10,000 patient. Nicholas will provide a huge data. But IVF, such huge data are not there. Okay, because we struggle to do RCTs in IVF because control arm mein kaun jayega? It's a big problem. Okay. So personalized approach. Since there is no big evidence, we will all go for a personalized approach. So what's a personalized approach? We will generally use 300 to 450 IU. You will use FSH HMG combos. You will give dual trigger. You do freeze-all, and now the patient fails. You did everything right. Nothing went wrong, but the patient fails. So what next? So you can use the same protocol. Again, if you get less eggs, face failure, the client is going to say, well, पहली बार भी mistake किया, अभी वापस mistake. You should have changed something. The client is not happy. And can you change the fate? As Dr. Goody said, no, you can't change the fate of number of eggs in a poor ovarian reserve patient. So you will like to make changes. You will give some pre-treatment. You will do some dose starting juggleries. You will do some random start, dual stim, etc. Now it still failed, but then at least the patient says, well, doctor, you tried your best. You got the difference? It's a psych. So we are not doing only evidence-based medicine. We are also doing consensus-based medicine. But beyond these two things is what we want to practice is a value-based medicine, which should make a value to the client, and our trust relationship between the client and you should be very strong so that they stick to you, they take more and more treatment cycles with you, and the whole thing goes better. So what are the variables in IVF? So you have non-modifiable variables like age and ovarian reserve. Goody just tell, you can't improvise the age. Neither the ovarian reserve, you can't improvise an ovarian reserve. You can't make somebody having a 0.5 AMH 2.5 one day. A 0.5 can become 0.75. It will be still statistically significant, but clinically irrelevant. Not every statistically significant thing is clinically relevant. You got it? So we're not going to make any changes there. Then there are some modifiable factors. BMI, modifiable. Metabolic syndrome, modifiable. Endocrinopathies, a long-standing hypothyroidism, a long-standing high triglycerides. Well, they are modifiable factors. Immune factors. You can ask your immunologist to get her SLE down. Can we get the rheumatoid SLE to its nadir? So that the inflammation stops and your disease or the egg quality, everything improves. So there are some modifiable factors also which we should be looking for. On top of that, infertility is a very heterogeneous disease. You will have a poor ovarian reserve with an AMH of, let's say, 0.5, and she is 90 kg. You have another lady with an AMH of 0.4, but she is 45 kg. ages are different, their weights are different, their histories are different. The trajectory of fall of AMH is different. Their FSH levels are different. On top of that, somebody has an adenomyosis, but she has an AMH of 1.5, and somebody has 0.5, has a beautiful uterus, and the other lady achieves her pregnancies faster than the AMH of 1.5. AMH is just one number. It's such a mixed, heterogeneous disorder that certain policies cannot be uniformly formulated. We will have to have a personalized approach to design a policy of treatment to the given couple in front of you. So different results in the same treatment in different patients. That's also very common. Bolinia criteria, they talked about the age, AMH and AFC, that the parameters of your ovarian reserve, and previous poor response. Any two of these three positive, you say it is a poor ovarian reserve. Age, again, you can't put all that thing in the same line. Age, AMH, AFC are known prior. Identifying a person with low intrinsic capacity regardless of stimulation. But this definition disregards the impact of quality and quantity together. Somebody who is 3 eggs of a 32-year-old lady and that of a 42-year-old lady are two different stories. You go with 3 eggs of 32-year, go with 2 stimulations, you'll have 6 eggs. With 6 eggs, let's say you have 2 blastoses, you have a pretty good pregnancy rate. With 42-year-old, let's say you have 4 blastoses, let's assume, but all 4 could be aneuploidic, and your chance of pregnancy is very, very low. So moment you put age in the basket, okay, the whole thing is, so they put Bolinia criteria. Before Bolinia criteria, that is 2011, it came in. Before that, there were 42 definitions of poor ovarian response, 42 definitions were there. And there was a paper published on what are the 42 definitions. Then came the Bolinia. Bolinia added again a problem to the thing because of the age include. The moment you make a combination with age, it's very, very different. So they published a trial, if I'm not mistaken, it's called ENGAGE trial. I could be wrong, but I feel it's an ENGAGE trial, wherein they looked at the stimulation for poor ovarian reserve patients. But in the whole trial, they did not include previous poor response. No patient with previous poor response was included. So very sad. Then they looked at the dosing protocol, Tilburg et al. They looked at dosing for poor ovarian response patients. Then looked at that paper, and then they did a secondary analysis. Somebody else did a secondary analysis of paper. They realized the Turkish group did not do AMH at all in the whole group. They had a multicentric trial, but all the patients came from Turkey. They did not do AMH. So about 40% of the whole trial did not have AMH, but they applied Bolinia criteria. You got it. So trials have their own fallacies, so they don't give us everything at a face value. I must say, I don't know whether that slide is here, but before I go to this particular slide, after the Tilburg paper, and they made a big hangama saying that, giving 120, 150 to 225 IU of stimulation is very good, etc., etc. And they did not report a cycle cancellation rate also. So Nicholas Polizos published a report, and even Shesh Sunkara highly criticized that trial, and they came out with a secondary publication which says that say no to small stimulations or your stimulations with low doses in poor ovarian reserve. As Dr. Goody said, FSH is already high. You have to take the FSH higher than that, so that means you need a higher doses. Lower doses will be associated with more cancellations, and even a cancelled cycle is a failure, and rather that failure reflects very bad on you. So possible risk of low oocyte recovery, it could be intrinsic because the ovarian reserve is low, or response related. The ovarian reserve is good, but the response was poor. So Positidian criteria, expected prognosis based on chances of having euploid embryos to transfer. 2 reasons why low oocytes are collected. 1, patient's intrinsic low capacity or a hypo-response, that is capacity is high, but suboptimal stimulation is done. So the suboptimal stimulation could be because of a low starting dose. It could be because of no added LH, no use of recombinant FSH. It could be a dose not matching the body mass indices. Longer stimulations are not given, shorter stimulations are given. All those things could be responsible. On top of that, we really do not know how much gonadotrophin will go to the egg. What is the ovarian blood supply? What is the impedance of an ovarian artery? And how much blood will really go? And that is a complete lacuna. We don't counsel the lady. Well, I'm going to give you a good amount of drug, but I don't know how much really diffused to your granulosa cells. And AFC3 developing 3 eggs in IVF, we never cancel. But let's say there's a PCOS, only 3 eggs are recruited. You will definitely cancel because you are not giving a good prognosis. You will correct it up and go with the next cycle. This is a very beautiful paper. Not many people would read this up. So ovarian response for the same dose and different stimulations in the same lady is different. And this trial could not have been done, but in this best way. In 2015, when they introduced corritropin alpha, Merck wanted to introduce, in corritropin alpha trial, they give corritropin alpha the same dose for same couple for 3 successive IVF cycles. And they looked at the differences. They always, low to high normal response, about 12%, 10%. So about 10 to 20% of the client will go either low to high, high to low. The response in every cycle will vary. It depends upon how many recruitable follicles are there at that particular moment. And that's where I feel indirectly what Goody is saying is AFC tracking is important. You track the AFC and start your stimulation, because the response, if you start every time on day 2, in the first cycle she may respond with 2 eggs, in the very next cycle she may have 9 eggs. So AFC tracking is very, very important. Is there a recommended maximum dose? I wouldn't go by these figures. I would say use maximum because we want to have a maximum output of the eggs. So I prefer giving a high dose for all my stimulations. Now, IVF cycle done, they fail. So what is the risk of a poor ovarian response in a repeat IVF cycle? Because this is one question your patient is going to ask you. Well, doctor, this is done now, all done and dusted. I want to go with repeat. But how do you think that will it be the same story? So low AMH, low oocyte yield, time interval between the cycles were independent markers of poor ovarian response. This is the most common discussion a client will do with you. And look at that. If you do the next cycle within 1 year, the low ovarian reserve is 57%. But if you go beyond 1 year, the risk of POR is 73%. 2/3 of the patient beyond 1 year will respond worse. So insist that they should do their second cycle, not after a long time, but a little shorter. This paper gives a very vital information to all of us. And it is always a shared decision making. We always do evidence-based medicine, the patient-centered communication, and a shared decision making. But now comes a different thing, and that is literacy skill of a client, or you say googly patients. So patients have Googled and come to you. So a shared decision making is between evidence-based, the Google knowledge, or now Gemini or Siri or whatever they are, Alexa or whatever, and your opinion, your communication skill with the client. Everything comes down to a path. So everything in reproductive medicine is a shared decision making. So we put on paper, we give this option. So we follow in our practice, we didn't mention this to everybody. So we strictly follow a cafeteria approach. So given any patient coming to us, we follow a cafeteria approach. We said how you can get pregnant normally, without any treatment, what needs to be done, how much time will it take, and what is the chances. If you do simple treatment, how much time, what chances every month. If you do IUI, is it necessary, will it make any difference? Will you do IVF, what changes, what cost, what is the timeline, and can we fail? So it's a cafeteria approach. And many a times the client will ask you, well, doctor, what is your approach? Then you come to whatever scientifically right, you say, well, this is my approach. But then I always say, well, this is my approach, I don't know whether you're mentally ready, financially ready, and physically ready to accept that approach. So I'm okay to sync with what you take a call of. And they say, okay, I will go for 2 months with this. I say, thumbs up, let's start off. And I carry it forward. Okay, so it's always a cafeteria approach, because since we face failures, it's better to have a cafeteria approach and then going ahead. And they love this approach because our industrial IVF partners don't have this approach. Our industrial IVF partners, their income is on how many patients are converted to IVF. For our common practitioners, our income is on how many patients get pregnant. Even if they're pregnant on letrozole, we are happy about it. There's no need to do an IVF every time to get them pregnancy. So emotional support, empathy is important. Time spent by the team with the couple is very, very important. So at my place, you can ask my fellows also. Number one, I give a counseling session of the timeline and how I'm going to do it. Then it is taken over by my fellow. One of the fellow will sit down with them and then explain the steps. Then it is taken over by my practice manager. My practice manager does the whole thing again with them. What is the timeline, what drugs, how many visits, etc., etc. Then they give a YouTube channel link, and we have all the videos of step by step of IVF in English and Marathi language. And then they go through the YouTube, and then we start it off. So because just one counseling round is not sufficient, you need to endorse 3-4 rounds, and then they come to know what exactly is going to be happening to us. So what are the limitations of adjuvants in POR studies? Bologna criteria only used after 2012. Very few RCTs are there using Bologna criteria. Even the gonadotropin protocols used themselves have a variation in dosages. People have used agonist stop, somebody has used antagonist protocols, people have used RFSH, HMGs, combinations, everything. So heterogeneity in data is there. Only general comparison is been done with different adjuvants used, but no studies available of the neonatal, perinatal, or obstetric outcome of the different adjuvants which are used in practice, because they are going to make a difference to the oocyte. So this is your mild to moderate versus full stimulation. Mild stimulation, the thing is, they say reduce cost, better compliance, no OHSS. But reduce eggs does not affect the fresh ET, but the cumulative live birth rate is going to be low. More eggs, more embryos, more euploid. Gone are the days, and this is a nice paper published by, I think, Barbara Lawrence in egg donation cycles. And they said when the number of eggs keep on increasing, your euploidy rate is also high. So it's all about full throttle stimulation, more eggs, more euploid, more pregnancies. No way we can improve an egg quality, so only we can improve the egg quantity by synchronizing, by your protocol, high dose, etc. Higher cycle cancellations, the odds ratio is 1.48 from 1.08 to 2.02. With lower doses. So all efforts must be directed to avoid cancellations. So Estivus in 2021, this is that, he said, analysis of 12,000 embryos. Euploidy rate is not affected by dose duration of FSH stimulation. This is again a common question to ask to all of you. You're giving so much of drug, so expensive. What are the side effects? They say no side effects onto you, no side effects onto the baby. The only side effect you will face is every day you have to take a prick, and you may have big ovaries with estrogen, some vaginal discharges, breast becoming heavy. That's all the side effect would be. Since there is no robust way to increase quality of oocyte, we can try to increase the number to maximize your euploid embryos. Okay, so and there's no evidence for mild stimulation. So what adjuvants commonly do is they lower the dosage of gonadotropins. Okay, that's one advantage. High dose FSH could be having a detrimental effect. That's what is said, but I don't believe into this particular sentence. I use a full throttle stimulation. So modern approach would be personalized diagnosis. You look at the etiology, risk factors, personalized prognosis on the age and BMI. You will take that call, and personalized counseling. What protocol will you be using? What lifestyle correction will you use? PGTA, oocyte activation during your laboratories, etc. All that will be done. And then, but you can have different heterogeneous disorders, isn't it? You can have tubal factor with high BMI and tubal factor with low AMH. This could be two different combinations, okay? And they have different prognosis. So 20% of all IVF patients will have a modifiable risk factor, and you should look into that modifiable risk factor. So I always put on my paper when the client comes, these are your good points. These are your problem points. I don't say bad points. They are your problem points. And this problem point I cannot answer because it's not modifiable. These are the problem points which is modifiable. And you give a good thing to them, then they are happy about a thoroughness of your counseling. So this is a systemic review and network meta-analysis published in 2020. There's one more network meta-analysis which has just been published in 2024, but I have not read that up on adjuvants. That paper I have not read yet. So they said aggressive stimulation could have side effects and costly, while natural minimal stimulation have low oocyte yield and face 40% cancellation rate. So adjuvants is just an additional complementary treatments. So this is a network meta-analysis which has been published. Network meta-analysis, you have one control group, and they look at every adjuvant used. The dot strength tells you the N number in the study. The thickness of the bar tells you the number of RCTs available on that particular study. So this is the kind of network meta-analysis interpretation we do. And look at the result. The result says that out of all the adjuvants used, it's only the coenzyme Q and DHEA where it is clinically relevant and statistically significant difference in the live birth rate has taken place. So I think these are very, very important. Growth hormone also is something similar. Okay, so growth hormone, CoQ and DHEA are the three accepted adjuvants for us. So growth hormone, DHEA, CoQ are the top three. HCG, growth hormone, estradiol, they resulted in number of oocytes. Testosterone, growth hormone are higher number of embryos transfer. This is the data which has been published, and coenzyme Q supplementation had the lowest cancellation rates. But the global effect is they reduce the gonadotrophin doses, whichever adjuvant used. Let's go one by one into understanding the adjuvants. Coenzyme Q. So coenzyme Q, this particular thing, where it originated, this originated with this particular study, coenzyme Q supplementation and oocyte aneuploidy in women undergoing IVF ICSI. This is a study by Robert Casper. So they looked at the treatment outcome in patients with coenzyme Q and placebo group, and top quality embryos were very good compared to the placebo. Top quality embryos at 72 hours, also very good, and rate of aneuploidy lesser than that of placebo. So that coenzyme Q definitely improves the mitochondrial activity and gives you a better outcome, very logical. But this came from this particular, the protocol they use, why 60 days, why that particular dose, why 60 days and why 600 this? This particular protocol, they got it from a mice study, a study done in mice. So 60 days of coenzyme Q in mice is 20% of its lifespan. It cannot compare to 60 days of a human treatment, isn't it? Okay, so that's one. And coenzyme Q, this is the mechanism this. So coenzyme Q is something which can go high and go long, no problem. You can go for 6 months with coenzyme Q. You can go with 600 IU of coenzyme Q, nothing wrong. So I was once sharing a dais with Fadi Sharara. I think Ferring had invited him, or Merck had invited him, and I was having a lecture with him in Pune. And I was just asking Fadi Sharara, how many Indian patients you get in US? He said, my 50% practice is Indians. So I said, what is the difference? I said, I just pump in coenzyme Q moment I see an Indian patient. And I just go 600 IU twice a day for 3 months and 4 months. I'm just pumping them on coenzyme Q. I think nothing wrong in following some strategy like that. So you can give coenzyme Q universally for these clients. What about testosterone and DHEA? The whole ethos of giving testosterone or DHEA, it goes to the body, it has to be converted to testosterone to have an ovarian action. DHEA cannot tell the granules, well, I'm there, don't worry. No, it has to become testosterone first and then convert. So in older women who have deficiency of an enzyme of converting DHEA to testosterone, it will not work. A younger woman who has a capacity to convert to DHEA to testosterone, it will work. The whole story of DHEA came from the he was doing Gleacher study. Okay, that came from, in US, DHEA or androgens are used as well-being, menopausal well-being pill. Okay, it was a health pill. It was basically a pill to increase libido in menopausal women. Okay, so when aging women took DHEA, few of them achieved pregnancies. And that started the whole concept of DHEA as improving in poor ovarian reserve or low reserve patients. That's how the whole thing started. So we have moved with that, and a lot of studies by Cousins et al. Was the first RCT published onto DHEA, and further RCTs were there. So intrafollicular depletion of androgen in poor ovarian reserve patients is observed. Testosterone will augment early follicle by increasing IGF-1 in follicle, stimulates the transition from primary to secondary follicles. That's why that's the whole ethos of giving testosterone. What is the benefit of 20 days of testosterone treatment for a oocyte which is developing over 70 days? That's a logical question asked. And this was a question asked by Nicholas Polizos, that everybody you're recommending 10 days and 12 days. And you know what happened? There were 6 RCTs on testosterone treatment, and there were some 11 systematic reviews published on 6 RCTs. And there was a nice paper published that we need to have control trials and so not systematic reviews on testosterone. The problem with RCT on testosterone was, you have a poor ovarian reserve patient in front of you, say, well, testosterone can make a difference, it's physiological, I would like to put you through. But we are conducting an RCT, so you are in the control group. How many of them will be ready to go in the control group? And that was the main reason why RCTs were low. So this is what disproportionate number of meta-analyses have been published compared to the RCTs. They said that role of we need to randomize and not meta-analyze. This was published by Nicholas Polizos. And he put this publication. Second, he put a publication on what 10 days of treatment will do for 72 days of folliculogenesis. So he came out with a trial called T-transport trial of putting testosterone for 70 days. Okay, to women. We'll go through that. So these are two trials. This is called a testoprim trial. Testoprim trial was published by the Sabag author and it came in RVM Online. What they gave was, they gave 3 different types of testosterone. They gave long testosterone group, maybe 60 days, 50 days, then 10 days, and then was a control group. So they said we need to give a long testosterone therapy because we want to push the follicles higher and higher. Look at that, what they did. So I have put the testosterone serum levels they achieve. In 50 days group, 167 nanogram. In 10 days, 303. It seems testosterone goes peak with in a short time, but then the level stabilizes. Okay, that's why the difference in spite of a duration being high, the levels are a little lower. And this is the control group. So this is your normal female testosterone level. And I'm just putting you for your reference the male testosterone levels. 19 years and older is 265 to 923. So these women were reaching in the male group. You're taking the testosterone to the male level. Obviously, it failed. They did not see any improvement with long-term testosterone therapy. So the whole understanding of reproductive physiology that you require higher androgens for a longer time so as to have a good follicular, it just failed. Okay. Then this is a T-transport trial. This is the Nicholas Polizos multicentric. I think there were 6 centers in in Europe where this is a T-transport trial. And he said we want this trial because we want to learn lessons from ovarian physiology. Again, give 70 days. So he quoted these trials saying that they are given different, sample size is low, the duration is different, and the dose of testosterone used is different. That's why we need a very uniform big trial. With that ethos, he went and published the T-transport trial. But again failed. He gave it for 70 days or 60 days of testosterone, 12 milligram a day or something, a patch of something, completely failed. They had to have an intermediate failure, saying that intermediate data analysis, and they stopped the trial. So testosterone level have a threshold to promote growth and a ceiling level beyond which it will inhibit folliculogenesis. So all those 2 trials where they use long-term testosterone proves that they crossed the limits of the androgen ceiling and that inhibited folliculogenesis. But when you look at trials which are published for 8 days and 12 days, they have noted a better oocyte number and embryo. But we still don't know how many exact days we need to give. We don't know what is the dose and who will benefit and who will not. Okay, so we have these questions. In my practice, do I use it? I use it because it is a consensus amongst in India that we should use that pre-treatment. So I use it not more than 8 days. Okay, and I give androgel 2 puffs. I think Intas and 2 more companies do it. 2 puffs of androgel to be applied on the inner side of the arm for 8 days or 9 days or around the umbilicus at night. That's the only treatment I give. I don't look at the size of the ovary, AFC, kuch nahi. I'm just giving it because there's a consensus of it in the community. So the question now is, shall we achieve a normal androgen and sex hormone binding globulin levels prior to embarking IVF stimulation? This is the right question to be asked. The problem with pursuing this kind of a strategy is we don't know what is a normal androgen level in an adult woman. Okay, we need to have that study first, then establish the 2 standard deviations on either side, then we define what is low androgen level and identify those women, then supplement testosterone to make them normal and then start stimulation. Nobody's taking, I think ISAR, IFS, FOXY need to take such kind of trials on headed, but then we are in a helicopter. And Baku trip, isn't it? Yeah. So DHEA, androstenedione and testosterone, that's a conversion, it's a pathway. So DHEA does not accumulate. Why we use DHEA? It doesn't accumulate. Okay, but then this is a wrong notion. I'll come to that. In all tissues, unlike testosterone. If you give testosterone for a long time, androgen levels will go up. We just saw that. DHEA, we don't do levels. Do we do it? We don't do it. Am I right? We just pump in DHEA. Our earlier consultant has given andro plus, you are giving andro fert, somebody will give andro gain. But they will all give DHEA, one from the other. Now, Norbert Gleicher again published a beautiful paper that high doses of DHEA for a long time is detrimental to folliculogenesis. So younger women convert DHEA to testosterone better. Low FSH women do well on DHEA. So low AMH, low FSH, young, she will do good with DHEA. Older women choose testosterone directly, while younger you can go for DHEA. Again, a short phase of testosterone. T-transport trial, well, no results improved. I just told you. Now, this is a beautiful paper by Norbert Gleicher on DHEA. He's the one who suggested everybody to use DHEA. And what he said is the micronization of DHEA has become better and better. That's why the absorption of DHEA is much better. He advocated 25 milligram once a day. Then it came to 25 milligram 3 times a day. And the moment it hit India, we had to have SR. तो साइक्लोफॉस्फामाइड एसआर भी आता है क्या? आएगा. कुछ भी एसआर कर सकते हैं इंडिया में हम लोग. So they came out with DHEA SR. So 75 milligram once a day. And there are combinations of DHEA with coenzyme Q, DHEA with coenzyme Q with Proginova. आएगा, कुछ भी आएगा इंडिया में. So authors noticed after about 12 to 13 years of use that significant increase in patients upon testing androgen levels after 4 weeks of DHEA, the androgens level has increased and dose reduction is needed. Now this because they started measuring androgens. We don't measure. We wait for the acne to develop at 40 years. Oh God, DHEA ज़्यादा हुआ अभी कम करते. So please start measuring androgen levels. So after this study, I have stopped using DHEA beyond 1 month. I just use it for 1 month and I stop it up. 15% of their population needed dose reduction. Lean women should be started, he said, go low. But अभी SR ने इतना मार्केट खा लिया कि लो अवेलेबल ही नहीं है इंडिया में. Okay. So micronization can increase absorption. Raw material from China now has increased biopotency. They also improved. Start 75 milligram for 4 weeks. Do total testosterone, free testosterone, sex hormone binding globulin, DHEA, DHEAS level at the end of 4 weeks. If high, step down the dose or stop the therapy. Okay, and then what are these are the cutoffs. If you start DHEA at the end of 1 month, if your patient is having any one of these cutoffs is crossed, you stop the therapy. Don't wait for the acne to develop or husband to steal the tablets and take also. Okay, just stop it up after 1 month. So in my practice, I just stop it after 1 month. I don't do these levels also because I don't expect much out of the DHEA. Growth hormone. I stop only, madam. So my practice is not to restart. I don't believe much. I believe in taking multiple IVF stimulation. That is more better than giving any supplements to improve outcomes. Growth hormone. Physiologically, yes. For the primordial follicle to become primary oocyte, you require androgen and growth hormone. It has to go coherently and then the follicle form. So this is 2022. There were a lot of the systematic review, earlier systematic review only supported growth hormone. He said growth hormone is the only thing which is worth it. The growth hormone supplements is senseless, but it is senseless in presence of a normal or high serum growth hormone levels. So indiscriminate usage will skew the efficacy results. After this paper, we stopped using growth hormone in our practice. Okay, not for its expenses, but it's no point using indiscriminately growth hormone. So we do blood growth hormone levels, and if it is low, less than 132 nanogram, we add growth hormone. Okay, so we do IGF-1 levels for all our low ovarian reserve patients, and if it is low, then only we will add growth hormone supplements. Okay, so this is a better policy. Why? This is the reason. Why? Okay, so they said that if your growth hormone IGF level is very high, you have more pregnancy losses. So high IGF, low IGF receptors. If there is low IGF receptor, low glucose transport to inner cell mass, that will trigger apoptosis and embryo demise is there. So there is no point giving undiscriminate growth hormone. See, what happens is in our conferences, we don't read papers, the negative papers. We don't read papers of secondary analysis of a published data, or what are the opinions of different consultants, what are letters to editors. These are the things which give you a lot of information where the trial has gone wrong or what are the fallacies of a trial. Or when you read a systematic review, you say, moment you say the heterogeneity is 40%. So we have to know why 40%, which factor made that systematic review heterogeneous, and we have to look into that. So we need to read a paper in the depth of it. That will only come if you start reading one paper a day. So my message to all of you is read one research paper a day. Down 6 months, you will be able to analyze something more. So IGF level, this is the paper, and they said the IGF level linearly decreased 2.2 nanogram per ml every year, and then they did look at the levels and group C number over the cycles. So what is it? I think when the IGF level is low or something, they have more amount of problem. That's what this is. This is again a Robert Gleacher study. So with very low pregnancy rates in low reserve women, oocyte numbers, embryo number, live birth rate may not reach a statistical significant. So that's why everybody had smaller studies of 200. In smaller studies, not going to convey. So cycle cancellation is an important parameter also of telling the success story of adjuvant. If your adjuvant therapy is decreasing cycle cancellation, it's worth an adjuvant. So cycle completion denotes one transferable embryo. Can growth hormone improve that? Yes, it does. So if you have embryo problems, you have done one cycle and the embryo quality was poor, it's worth putting a growth hormone therapy to them to improvise on the embryo quality. If you can avoid a cycle cancellation, make one embryo transferable, the whole negativity shifts to implantation failure, which is an acceptable negativity. Failure not to get an egg or failure of cancelling the cycle halfway through is not an acceptable negativity. They will blame you for everything. 12 IU per day growth hormone light study, 4 IU by Lee et al. So we use 4 IU in our practice. Starting in the preceding luteal phase is better. A subgroup of women with poor embryonic growth will benefit more, that which I told you right now. What about androgen priming? That's what the letrozole Dr. Goody was telling you about, and Dr. Sheryu just told you about a follicular phase letrozole and luteal phase start, and that is nothing but the androgen priming. So increasing intra-ovarian androgens increases the FSH sensitivity and better oocyte number and quality, and you can use HCG, LH or letrozole. These three options are. I give about 8 to 12 doses, not more than that. We have not crossed 12 doses, isn't it? 12 is the maximum we are given. This is a study by Won et al. From Vietnam, and you should read all her studies. She's a very good publisher, and she's blessed by Peter Humaden. Peter Humaden is always there in all her studies. And what they give is, just look at the protocol. The protocol will tell you why they failed. The GnRH agonist depot was given, then they gave one more depot, and when the patient was under depot influence, they gave androgen 250 IU every second day and letrozole. They had to give depot because otherwise the ovaries will have become cystic. So they could not give letrozole all the time. You got it? So they gave depot. So they suppressed the pituitary ovarian axis, and now they are giving HCG, allowing the HCG letrozole to act only on the ovaries but not form follicles. So it will increase the intra-ovarian androgen. Logical. Okay? And then this last cycle they stimulated. Look at the doses. They all used 300 IU. Okay? They stimulated and looked at the outcome. So androgen priming at 4 weeks and 8 weeks. Look at the AMH level, it's all the same. FSH did come down. Obviously, LHFSH will come down because it is agonist protocol. Agonist depot was given, so it had to come down. Estrogen also came down, progesterone, all okay, testosterone, fine. 1 minute. I did not put a result. Well, this whole thing failed. They were not able to show any improvement in the number of eggs obtained, or there was no improvement at all seen because they did everything in a suppressed environment. Okay, so it is still not physiological. And this is another study where they give HCG and aromatase inhibitor in this. Again, they noted a little high in AMH. AMH just went up in the group 3. But again, not one of those accepted things. So we do follow this in many cases. So, I want to do a luteal start stimulation. Late luteal is my favorite place to start stimulation. I will start patient on letrozole, allow the follicle to rupture, take her to the late luteal. I've done my androgen priming and then start my stimulation. That's my favorite protocol. That's my favorite duostem for low ovarian reserve patients. And this obviously it's an antagonist protocol which will be used. The best is to accumulate eggs and embryos. So double ovarian stimulation, which is been described, but I don't do this. I just do conventional stimulations multiple times to accumulate this. Duostem allows accumulating top quality embryos in shorter times. There can be some laboratory adjuvants which you can be doing so as to improve the outcome in poor ovarian reserve patients. So this is that reviews and reviews papers which are there. Forget 2019. Just go to 2019 ASRM. I'm sure in fertility study you'll get these papers up. And these are the laboratory adjuvants, but nothing made a difference. Nothing is in green. Okay, so they said you can aspirate even the smaller follicles, give dual trigger, look for blastocyst transfer, and in Posidon 2 group, when the age is beyond 35, do PGT, and that will improve the results. Next is when you get zero oocytes. You go through the stimulation, you get zero oocyte, what next? The client is asking, what changes will you do so that I can get an oocyte? And is there a sufficient proof? Okay, we are not discussing empty follicle syndrome here. Everything is right, but we have got zero oocytes. Okay, in a way it is empty follicle, but everything is nothing pseudo here. It's true. And this was expected zero oocyte. Empty follicle is in a younger group. This is not a younger group. This is not a normal responder. It's a poor ovarian reserve which you are not getting an egg. So these studies can be done only in Israel. Because in Israel, any number of IVF cycles till the age of 45 are free. Okay, and when they do embryo transfer, the whole family is in the chamber, and they all clap when the embryo transfer is done. Okay, so they want more Jews to be born. So they looked at 9 cycles once they got zero oocyte. They did 9 cycles further. I want you to look at the FSH dose used. Look at the FSH combination. Kitna dose use kiya unhone? Okay, they used about 6,000 IUs, 5,000, 6,000. So they went high. They did not go low. Okay, and whatever E2s, etc. High dose FSH, they were given subsequent cycles. On what happened? Yeah, I'm just putting the, look at that, what happened. So cumulative pregnancy rate per OPU per patient and cumulative live birth rate, well, there is an improvement with further cycles till about 5 cycles. Beyond 5 cycles, there was no improvement in pregnancy rate. So even if you get zero oocyte, if the patient is willing, nothing wrong. You can push for one more, but use higher doses and do AFC related start off. This is a beautiful paper. In the morning I was discussing with somebody on this particular paper. That suppose this is a novel strategy, Fertility study, nice one. And I've not done very frequently, but now Luveris sadly is not available to us, but I would love to do something like this. So they gave long agonist, they got menses. After menses, they gave Luveris, RLH, recombinant LH, 150 IU for 7-8 days. So this is ideal, isn't it? Giving LH injection will increase the intra-ovarian androgens. And now you start the stimulation. Again, look at the dose, 400 IU. They are not gone slow, high stimulation. And what part was beautiful part is they selected this very uniform population. They selected women who have 2 failures with high dose, 51% cancel cycle during earlier stimulation, 40 embryo transfers were done, only 3 pregnancy, but all aborted. So no live birth in the previous cycles. Very uniform population and homogeneous population. And then they were randomized to LH pre-treatment and no LH pre-treatment. Look at the result with LH pre-treatment. Well, they noticed 24% pregnancy rate, while the previous cycle was 0%. Worth it, very physiological I feel, very, very physiological. Sadly, RLH is not available with us. So hope if the liver is there when this is something can be practiced. Again, this question you are asking, can we give Proguanil for a long time? This is that paper. If when all is lost, ultra long estrogen priming cycle offer a good pregnancy rate. So they give oral then they kept on giving estrogen priming Proguanil for a long time, and then they looked into this particular study. But this is just one study, not able to put it up. Well, thank you so much for all of you.